Hello, everyone. Bonjour. Buenos dias. Howdy. My name is Marian Pitters, and I'm absolutely delighted to be the facilitator for today's webinar. I'm here to introduce our speakers, moderate some questions from you, our audience participants, and ensure that the webinars progress according to the schedule so we respect everyone's time. But first, on behalf of McMaster University, it's my pleasure to welcome you to the 8th of the 10-part series, Expert Perspectives on Pandemics. We have participants from all over Ontario, Canada, and the globe online today, graduate students, faculty from McMaster and partner institutions, as well as representatives from the Pan American Health Organization, PAHO, the World Health Organization, WHO, and some select invitees. Many of you are preparing to contribute your skills to mitigation of the COVID-19 pandemic. We welcome you all to today's compelling session. The COVID-19 emergency presents a global challenge to our healthcare systems, our economy, and our ways of living. In the face of this unprecedented global health crisis, McMaster is dedicated to innovation and collaboration in the discovery of solutions to help combat COVID-19. This series is integral to the Master of Science in Global Health. Experts will delve into topics including historical trends, vaccine development, the threat of antibiotic resistance, and Canada's research response to COVID-19. A quick overview of the 10 webinars in our series can be found at the link where you registered, globalhealth.mcmaster.ca/2020 webinar series. Today's session is webinar 8 of the 10, Perceptions of Past Pandemics, Cultural Histories of Public Reaction to Disease Outbreaks. It features Dr. Sonya de Laat, the Academic Advisor of the Global Health Program here at McMaster University. A final housekeeping note before we start: time has been built in for questions and discussion. At the end of the webinar, please use the chat tool to submit questions electronically. And note that while we may be not able to get to all of your questions, our speakers will aim to address them afterwards on the Global Health website. At this point, I would like to introduce Dr. Andrea Baumann. Andrea is the Associate Vice President of Global Health, Faculty of Health Sciences at McMaster University, the Director of the Master of Science in Health Global Health Program, and the Director of the World Health Organization, WHO, Collaborating Center in Primary Care and Health Human Resources. Andrea, will you please start us off with a few words about launching this webinar series?
Yes, thank you very much, Miriam. I would just wanted to welcome everyone, thank everyone for joining us for this webinar. At our first webinar, Dr. Paul O'Byrne was with us, the Dean and Vice President of Faculty of Health Sciences at the Michael D. DeGroote School of Medicine and Faculty of Health Sciences. I know he wants me to continue to welcome everyone on his behalf. These are challenging times. We organized this series to reflect the transdisciplinary nature and complexities of global health. Each speaker focuses on a very specific area to give you an idea of the variation of perspectives that exist as we undergo this recent pandemic. I want to thank all of the speakers for sharing their diverse and expert ideas, and our students as well from 4 or 5 universities that are in our Global Health Consortium. It's been an unprecedented learning experience for us all, and our privilege to organize it. So we look forward to today's lecture. Thank you, Miriam.
Thanks, Dr. Baumann. Before I introduce our speaker, another quick reminder to post your questions during the presentation in the chat box, and we'll get to those right afterwards. Now on to our speaker. Dr. Sonya de Laat is the Master of Science Global Health Program's Academic Program Advisor and Curriculum Coordinator. Her academic background is in anthropology and media studies. Dr. de Laat's research interests span visual histories of humanitarian action, humanitarian health ethics, and visual research methods. She's an active member of the Canadian Network on Humanitarian Histories and Humanitarian Health Ethics Network. When not researching humanitarian health initiatives, Sonya volunteers with her kids at Westfield Heritage Village, bringing the histories of 18th and 19th century unsettled Ontario to life. Since the onset of the pandemic, Sonya has begun relearning the piano, something she hated as a kid, but has come to appreciate as a welcome distraction these days. Dr. de Laat, we look forward to your perspectives on perceptions of past pandemics, cultural histories of public reaction to disease outbreaks for the next 30 minutes or so. I'll provide you with a reminder, and then we'll invite you to engage our global participants in a Q&A session for 15 minutes. Over to you now.
Thank you so much. Hello, everyone. Thanks, Marianne, for that great introduction. Thank you to Dr. Baumann for making this opportunity possible, and to everyone on the Global Health team that's been working to support this speaker series. I will actually be turning off my video after I've said my hellos, so that you can focus on my words and the slides rather than me. First, pull up the slides. Okay. So I would like to begin by acknowledging that the land on which I'm making this presentation is part of the traditional territories of the Mississauga and the Haudenosaunee Nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. I also want to acknowledge the Inuit of Nunat-Siavut, who are among the first people of Labrador, and some of whose stories are shared in this presentation. Much of the research I've been involved in has been with the Humanitarian Health Ethics Research Group based here at McMaster and at McGill University. From 2016 to 19, I have had the good fortune of being a co-investigator on 2 studies with them. One on learning from participants and local healthcare providers' perceptions of international research conducted on Ebola virus disease during the 2014-15 outbreak in West Africa. And the other explored moral and practical dimensions of palliative care in 4 different humanitarian crisis settings. My personal contributions was as a qualitative researcher, but also in mediating those experiences through parallel research into the history and visual culture of health experiences. With that, my scholarly community expanded as I connected with scholars around the world who had similar interests in visual histories of aid, and it's a growing community. Having since become an active member of the Canadian Network of Humanitarian History based at Carleton University, much of my work of late has been on visual histories of aid, for which I'm still learning more about how it relates to COVID-19. So this presentation today goes into a bit of a broader field than that specific research, exploring its surrounding historical context, let's say, and focusing on the benefits or value of historical thinking in today's situation. As an outline, I stick to a relatively near history going back to the mid-19th century. Of course, histories of people's reactions to disease outbreak go farther back, but in 30 minutes, this is still a rather surface-level look at history, and my hope is that I'll be inspiring you to go into your own research. So we'll begin on Staten Island in the 1850s and its ties to current protests in the United States. We'll then move on to the period of the 3rd pandemic, where the role of photography in shaping public reaction and understanding back then have echoes and reverberate today. And finally to the influenza pandemic of 1918-19, where we'll be able to get closest to individuals' reactions, offering insight into how patterns of responses then parallel or transect those today. I conclude with a reflection on meaning that we can derive from these histories as we move into the next phase of this current pandemic and continue to plan for future ones. Let's begin. Picture this. On the 1st of September, 1858, as thousands of people lined Broadway Avenue in Manhattan to celebrate the completion of the transatlantic telegraph cable, a symbol to many of a shrinking world and the makings of a so-called peaceful global citizenry, on the other side of New York Harbor, on Staten Island, people were preparing for an altogether other sort of gathering, one of a more sinister kind. Residents in the villages that abutted the quarantine Marine Hospital were finally fed up with the lack of action on their repeated attempts to have the facility closed or relocated. In operation since 1799, the quarantine facility was similar to many around the world at the time, Canada's was located in the St. Lawrence Seaway. As the first point of landfall for new immigrants or for returning merchant ships, it was the state-of-the-art means of controlling the spread of many diseases endemic in the era, such as yellow fever, smallpox, typhus, and cholera. Residents of Staten Island had long protested its existence, claiming it as the source of recurrent outbreaks in their community, although there's not enough evidence to really determine whether those outbreaks originated from the hospital or were just part of what was the normal disease cycles at the time. By the summer of 1858, tensions were at a breaking point as a decade of seeking change through legislative means was proving futile. In August, local residents began gathering bales of hay and straw mattresses near the walls of the hospital, signaling the seriousness of their frustration. On the afternoon of the 1st of September, the local Board of Health, made up of the same frustrated residents and others sympathetic, posted bills on the walls of the hospital and around town with this statement, and I quote, "Resolved that this board recommends the citizens of this county to protect themselves by abating this abominable nuisance without delay." With that encouragement, the facilities were set ablaze by local villagers who over the course of 2 nights added fuel to the fires until all buildings, hospital buildings, staff quarters, storage and carriage houses were reduced to ashes. Luckily, only 2 people perished, one with advanced yellow fever, and another was murdered as someone took advantage of the mayhem to settle an old score. In the trials and investigations that followed, it became clear that a variety of factors did contribute to this outcome. For some residents, it really was a fear for personal and community health and safety. Alongside that, there was also a lot of blaming and scapegoating towards the facility, and more specifically to the stevedores, who were the most numerous of the staff working at the facility. These were mainly new immigrant dock workers who were seen as vectors of disease as they ferried people and cargo to the quarantine hospital from the ships arriving from overseas. Their numbers also meant they could swing local elections. Historical consensus, however, is that the primary reason for this violence was for personal benefit, as the 2 leaders in the arson attack were major landowners who saw the hospital's 30 acres of ground as prime development land, and the hospital was a barrier to their profit. The land, I should say, is near where Staten Island Ferry lands today. Shocking as this event is, it's not unique in history or specific to just the United States. Indeed, we can find more recent examples on the other side of the world. In 2003, Chinese residents set up blockades and destroyed buildings, included school buildings that were being turned into SARS quarantine facilities. And even more recently, in January of this year, Hong Kong residents protested, as can be seen in these photographs, the transformation of a new and yet unoccupied apartment building into a COVID-19 quarantine facility. Then there are the protests for the last couple of weeks in parts of the United States. While protests against quarantine, it was not about the fear for personal safety or risks posed by those quarantine facilities, but rather its opposite, protests against self-isolation itself and nationwide requests by health authorities to physically distance, with protesters being willing instead to risk their health rather than stay at home. So what do we make of these historical events? Are they connected, and how? It would take more investigation to see if protests in China and Hong Kong are based in similar root causes or sentiments as those in the United States, but at the very least, it reveals a pattern across time and space to legal enforcement of public health measures. The protests in the United States today have much stronger historical ties to the Staten Island quarantine war, as it's now come to be known, particularly with respect to the role of authorities, today even involving the United States presidents, encouraging civil disobedience and even terror, or for using public health as a veil to condone violence for personal profit. President Trump's language in relation to the recent protests has even been described as incendiary. Now, while I'm not aware of his flame-throwing language being followed by the burning of buildings, it certainly appears to have encouraged people to storm state legislatures, sparking different sorts of fears. So having gained this little bit of American history should have us questioning and preparing for what might possibly follow. I also wanted to point out that the scapegoating and discriminatory reactions by Staten Islanders in the 1850s have been a long long been a pattern of people's reactions to disease outbreaks and is a pattern that continues today. So here are some headlines from Wikipedia pages tracking xenophobic and human rights violations and stigmatization, and also conspiracy theories coming from all levels of government, which has led to real serious consequences. In this photograph on the bottom right is of a man who died in Sydney, Australia, in Chinatown earlier this year, and no one would come to his aid for fear that he was contracting coronavirus. So what I have just shared is a little cultural history of health and disease outbreaks. Cultural history offers a means of accessing perceptions at a population and interpersonal level. It's less about actions or biographies of great people and more focused on everyday people's ideas and thoughts. Not so much what they thought, but how they thought and believed what they did. So for instance, how are decisions made? How were fears and distrust of others developed? How were rationalities formed and justified? Incorporating these histories into the present is what's called historical thinking, finding value in the present of the stories, experiences, and beliefs from the past. To do so requires remaining true to the past, to stick closely to the thoughts and imaginations of those who came before. Historians teach these 5 C's to help reinforce that practice. They include the recognition that change happens over time, that contextual detail is critical to an understanding of the past, a recognition that causality often means having to sift through many versions of events, that human life in the past is just as complex as it is now, and that events don't always unfold as we or actors from the past might have expected them to. This is the nature of contingency, which also reinforces the reality that more things, more events are interconnected than one might otherwise have expected. To work with history, we have to be careful to not break the first rule of historical study, that of anachronism. Anachronism is the danger of judging or interpreting the past as if it were the present, just dressed up in period costume. What this does is a disservice to the past. It's an injustice to those who came before, while also leaving us in the present with incorrect information on which to build or shape ourselves. However, we also have to accept that there's no unmediated access to the past. As one of my favorite cultural historians, Robert Darnton, is quoted as saying here, "We often look to the past with particular agendas or out of specific pressures that will undoubtedly impact our understanding of the past, or at the very least, shape its relevance in the present. This requires sensitivity on the part of historical thinkers, something I'll leave you to be the judge of how successful I am in this presentation. But ultimately, it's an important reminder for us when we're working with history. Here are some of the 3 reasons why historical thinking is valuable today. History gives us an ability to gain perspective on the present and can provide correctives to dominant or official histories. It helps us identify root causes of current situations or issues that can help us develop contextually relevant and lasting solutions. And 3, looking at the past can help generate different questions, giving us a chance to see current situations or problems from new angles. Just a quick example of how I've used history in one of the research projects I've been involved in. Fear and stigmatization was a large component of the Ebola outbreak in West Africa in 2014-15, not just within the countries that were affected, but also around the world. Such fear and stigmatization could lead members of affected populations to avoid seeking treatment until the disease is at an advanced stage. At a global level, this fear and stigmatization can delay or prevent international assistance or even interest in researching different treatments or vaccines. I produced a brief publication finding parallels in cultural histories of the so-called Spanish flu to those of people we interviewed in Guinea, Sierra Leone, and Liberia of their experiences of having recovered from Ebola virus disease. With this intervention, I intended to point out that it's normal for new diseases to bring with it fears of the unknown, along with myth and misinformation. By drawing attention to that pattern and to similarities and to people's lived experiences with being sick, there's a chance to introduce a degree of normalization, hopefully enough to reduce fears of seeking treatment and to encourage researchers to start in earnest with the hard task of finding effective treatments and prevention. This was just one example of parallel experiences I identified. hear about the overwhelming sense of despair by those who got sick at the peak of their illness. Other parallels included disease presentation and also experiences of stigmatization by those who were sick. This also adds perspective to our current situation. There are many things that we still don't know about the COVID-19, which is frightening, but we at least know it's a virus and have a century's worth of additional medical knowledge, including social determinants of disease, which should, in theory anyway, lead to more effective and equitable interventions sooner rather than later. So how then do we access the past? History, as we know, is frustratingly fragmented. We have to rely on documents, material artifacts, visual arts, and, since the mid-19th century, photography to help us reconstruct the lived realities of those who came before us, no matter how limiting those artifacts may be. As for the historical significance of photography, we have to remember that the camera was a brand new medium in the 19th century. Try and imagine how new digital technology and social media was for us 10 to 15 years ago, and you'll get a sense of how disruptive, almost revolutionary, the introduction of the camera was. For the first time, people could look at aspects of the physical world that would have otherwise been impossible to see with the naked eye. They could linger over scenes and have access to parts of the social and cultural world that were otherwise overlooked or reserved for the very few to be able to witness. The history of photography is deeply intertwined with the history of medicine and human sciences. Photography, like these photographs of the third plague pandemic, proved invaluable and instrumental in advancing medicine and can be considered a precursor to what we now consider global health. The creation and circulation of such photographs helped share information on disease presentation and supported the study of disease etiology, epidemiology, and treatment. Both photography and medicine were seen as science as well as an art. Many of the first practitioners of photography were pharmacists who had access to and the skills necessary for working with photographic chemicals, many of which were used, rightly or wrongly, as medicinal purposes as well. The third plague pandemic spanned the globe, leaving no uninhabited continent untouched and roughly 12 million dead. It has been described by colleagues of mine who have been studying its photographs at the Crash Centre in Cambridge, UK, as, and I quote, "the pandemic that changed the course of modern medicine, but which is also generally forgotten today." This was in fact the first global pandemic to be recorded visually, creating a new genre of images, epidemic photography. You'll see that the themes they identified in their analysis were reflective of several I'm covering today, including resistance to public health measures. At the time, the photographs did much in the way of helping medical researchers and local authorities learn about and try to manage or mitigate the disease. But from today's perspective, the visual record can also help us identify where epistemic, social, and/or political prejudices may have played a role in mistreating the disease or those it affected. For all the good and promise that photography holds in terms of being able to connect and unite people, photography has also played a role in dividing and maintaining separation between people, and that's certainly also the case with medical and scientific photographs. Othering is a risk that, when working with visual representations and other historical records, occurs when we treat the past as somehow strange. Othering is what anthropology as a discipline actively works to overcome. Techniques such as participant observation and ethnography are methods applied in an effort to make the strange familiar. Othering is something I inadvertently found myself doing at the beginning of this pandemic lockdown. When initially I was looking at photographs of Italy at the height of their being overwhelmed with COVID-19 cases, the photographs appeared foreign to me, so alien, so incomprehensible that they almost seemed boring. That is until lockdown took its full force here in Canada. Excuse me. Then all of a sudden, those photographs took on a whole different level of significance. I could feel the anxiety and exhaustion on the part of healthcare providers. The tension is almost palpable in photographs of people doing something that until a couple of weeks before had been the most mundane of tasks, grocery shopping, and then the repetition and banality of life lived mainly indoors. This experience made me read archival photographs of pandemics with a whole different significance. I had a greater amount of empathy for those in the older pictures. And this brings up an issue on the limits of historical analysis, but we won't get into that. We can have that discussion afterwards if that interests you. Going back to othering in the historical, medical, and scientific photographs, a particularly egregious commonplace practice of othering that took place at the turns of the 19th and 20th centuries was the practice of not naming people in photographs, or worse yet, classifying them by type, racial, ethnic, or other social category, which generates and reinforces stereotypes by denying people the basic dignity of a name, and individual identity, and autonomous agency as human actors. Such photographs are probably familiar to you. Sepia-toned images of usually naked specimens in frontal or profile view, often standing next to measuring sticks. I've elected not to display any of them here out of respect. Variations on that kind of photograph were common practice by photographers, travelers, and colonial agents. But in some jurisdictions around the world today, there are attempts to rectify that injustice. Project naming, referred to here, is, as far as I know, the first of its kind, and it began in 2002 in collaboration with Library and Archives Canada and Nunavut Sivuniksivut College in Ottawa, where they worked with descendants to add names to the archival pictures. Another way of overcoming the risk of othering is to access voices of those who witnessed history. Prior to audiovisual recordings, this could have been found in personal diaries, their correspondence, or one of my favorites is the notes in the margins of texts. Today, we're fortunate to have videos enabling us to see and hear from witnesses to history. This is a screenshot of an interview with Edna Boone, 100 at the time of this interview and aged 10 at the time of the 1918 influenza pandemic. Listening to her, we get a deeper sense of how people coped with uncertainty and fear while still reeling from the impact of a global war. Her family, who were fortunately spared from the sickness, managed to provide what care they could to their neighbors, showing us an example of how communities and individuals generate resilience in times of great pressure. She tells of leaving soup in mason jars on her neighbors' porches and of a community bonds growing stronger despite the many losses. She also had a message for people of today to study and learn from past pandemics and to prepare for future ones. Warning, and I quote, that the shock wave when something like this happens kind of stuns people, you know? They go beyond thinking correctly if not prepared. And sadly, if we look at some of the reactions around the world today, I think she's right. Popular culture of the time also provides added insight into how people coped and the concept of resilience. Here we see Nona and John Byers making the best of quarantine in Telluride in the black and white photograph. Telluride, Colorado. There's comic relief about mask wearing, something that I think that we are growing more familiar with. Or children's skipping songs that again normalize an otherwise frightening disease. And this remarkable song, written by the formidable Québécois folk singer La Bolduc about the flu. Still before influenza was understood to be caused by a virus, she wrote this song in the early 1930s with lyrics, translated here from French, that many of us will be able to relate to today. All the 15-cent stores are making money like water, Kleenex by the dozen, and for those with head colds. It starts with shivers and then we sneeze, and when you've really got it, it's time to get some care with a little gin and tonic. And I have to point out that in her refrain, she includes a sneeze onomatopoeia sound as well. So how people coped and managed with stress, uncertainty, and the unsettled reality of the time parallels what many of us have done in the past weeks, at least those more fortunate among us. For many, reactions and responses have been to tragic losses and tremendous sorrow, isolation in its worst form, even abandonment, not only among individuals, but also whole communities and possibly, as time will tell, but let's hope not, as whole nations. This, shamefully, was the case in 1918 for Inuit living in Okak on the northern coast of Labrador. While in the rest of Canada, around 50,000 people died of the influenza pandemic, Okak is among the hardest hit communities, possibly in the world at the time. In the span of 3 months, 200 of the 263 inhabitants of Okak died, what amounts to 7 in 10 people dying, leaving many children orphaned and its survivors traumatized. Flu was brought to their community by the always anticipated supply ship shown here in the top right-hand corner. Again, we're fortunate to be able to hear the voices and listening to the harrowing memories of 4 survivors interviewed in the early 1980s for the National Film Board of Canada. Watching photographs made of them in their communities and adding to that the visual archive of oral histories, we learn about how the speed with which the disease ravaged the community, forcing them to burn homes as a rudimentary form of cremation, and were left vulnerable to sled dogs driven wild with hunger with not enough humans to feed them. It was months before authorities in Newfoundland knew of the devastation in Okak, but it may not have made any difference. A more shameful response comes from a cabinet minister who, when he heard of similar challenges in other parts of Labrador, he's quoted as saying, "Let them die, it'll save us having to feed them," revealing a racism that runs counter to the image many may have of Canada. Okak is a horrific story of abandonment, while also a powerful one of resilience and surviving with trauma. I urge you to watch the film and read the book that came out in 2018, ironically, with a foreword written by Theresa Tam, Canada's Chief Public Health Officer, who has in the past weeks become a household figure. In it, she says, addressing disparities is an important public health intervention as important a public health intervention as finding vaccines. Disparities, sadly, that have not been addressed in the 2 years since this book was published, but which should attune us all to the disproportional impact the current pandemic will have in marginalized communities in Canada and around the world. And it thus makes sense that many First Nations and Inuit communities have closed themselves off as a protective measure, considering the unequal distribution of healthcare in those communities. Similar abandonment occurred during the Ebola outbreak of 2014-15. International aid organizations were sounding the alarm bells for 4 months, trying to get the World Health Organization to declare the outbreak a public health emergency of international concern, so as to mobilize international resources and mount a more effective response to the outbreak. As we've learned through a study I've been involved in with these fabulous researchers at Western and McMaster on triage planning during the current COVID-19 pandemic, ironically, perhaps, countries like Guinea and Sierra Leone, who may fare better now than other countries in the world, particularly in terms of social acceptability of physical distancing or self-isolation measures. Guinea, for instance, also has a stockpile of equipment left over from the Ebola outbreak to help in their COVID response. And the social memory of having been able to emerge from Ebola will help its citizens live through, and dare I say maybe even thrive through this pandemic. We may have a lot to learn from their history and their present. So in conclusion, these are but a few histories of people's reactions and responses to pandemics and outbreaks. There are scores more. Perhaps this will inspire you to seek out ones of relevance to your personal interests or situation. I'd like to finish with the words of philosopher Richard Rorty that ran through my mind as I prepared this presentation. Referring specifically to the mid-19th century moment with which we began this presentation, he claimed that the sad stories of disaster, conflict, and disease that traveled in more detail and with unprecedented speed thanks to technologies like the telegraph and the camera, expanded the concepts of one of us, people like us, resulting in greater efforts to address social disparities, herald an era of sweeping public health measures, and eventually introduce concepts such as universal human rights. That there continue to be recurrences of such sad stories over time should not be seen as a failure of humanity, as if progress were to move in a linear fashion like that. Rather, we should recognize in these recurrences examples of the heterogeneity and complexity that is humanity, and also find within them patterns that can arm us with insight, knowledge, and imagination to help us innovate our way out of current and future vexing problems like this pandemic and beyond. Thank you very much.
Thank you, Sonya. That was quite a presentation. Just wonderful. how you've been able to tie together some threads across time. So we'd like to remind our participants today that you can submit more questions in the chat section. They're flowing in, Sonya, so I hope you're ready to respond to some of the questions that are coming up. First one, I think many of us recognize that we are living in an historical moment. Given your presentation on the value of cultural histories, what would you recommend that people today make or keep as records for people in the future? Because we're seeing a lot of pictures and information coming through various channels to our screens. So can you help us sort through what you might recommend for people to keep or make as records for people in the future?
Sure, great. Yeah, thanks for that great question, Marianne. Your voice was cutting out a little bit, but I think I got it. So yeah, there are quite a few historians actually who are also recognizing this as an important moment to gather information on. And I know of earlier on when the lockdown situation started to spread around the world that numerous historians were beginning oral history projects. And I think those are really fascinating for us to think about in the future and to be able to return to. A colleague of mine at the University of Maryland School of Public Health, Marianne Moser-Jones, is working currently on a project gathering histories and oral histories from frontline workers and nurses about their experiences. At a personal level, I think we might also want to record our own experiences within our families to get some of those everyday experiences captured for future reference as well.
Okay, thank you for that. Having just gone through Mother's Day and a birthday, it reminds me of that because people started referring to my COVID Mother's Day, my COVID birthday. And so it really marks that those particular events are different because of COVID. So I certainly hear what you're saying on that particular item. It really strikes home there. Are you able to share some of the highlights from your research on triaging during COVID? Or is that something you need to wait for? Or is there anything that's coming up that you might share with us? So again, I'll repeat the question just in case I'm cutting out for people. Are you able to share some of the highlights from your research on triaging during COVID? Is that something you're able to share with us at this point, or do you need to wait for the results of that?
Well, yes, so we're just in the middle of doing the rapid analysis of those interviews. I can say that we have completed 53 interviews to date, and from all over the world. We're looking to interview frontline healthcare workers based on the WHO regions, so the 6 World Health Organization regions as the way of dividing up the globe. And so while we're still in the middle of doing that analysis, it's hard to comment too much on what it is that we're finding. But when I was thinking of this presentation and thinking back to what was the differences between the experiences in Guinea and other parts of West Africa from their experiences with Ebola versus with COVID-19 today, I found it interesting from one of the interviews with a frontline healthcare worker in Guinea is how much they're prioritizing triage based on age in a different way than it's happening here in Canada and in other parts of North America. Whereas in some parts of the world, age-based triage will have it that elderly people will probably have presumed do not resuscitate orders. In places where there are fewer elderly people and a much larger young population, there's a perception that the elderly are, and this is the description that was used by the participants that we spoke to, that the elderly people are precious as gold, and so they will do everything to protect the life and to support life for the elderly patients. So I found that a very interesting difference in some of the findings that we're hearing about making triage decisions around the world.
For sure. One of the things that comes up that you mentioned was anachronism, the danger of interpreting the past as if it's the present. And one of the things that continues to come up is almost a lack of acknowledgement that we've been here before. We've had pandemics before. We've had epidemics before. And yet there's a hesitancy to acknowledge that and to speak about this particular pandemic as though it's something completely different. Can you talk a little bit about that, around how our understanding of the present, it's almost like people are denying we've been here before, we've done this before. Can you talk a little bit about how you deal with that in your research?
That's a great question. So yeah, I think a lot of people are afraid to make too many assumptions in the present based on experiences from the past, and I think we often don't even recognize that there are some connections that we can make with the past, thinking that we have moved so far beyond that previous experience. I hope that through some of the examples that I provided, that we can see that there are still these echoes and traces of people's experiences with past pandemics and past outbreaks that still have resonance with us today, despite the fact that, yes, we have moved quite significantly farther along in terms of scientific knowledge and medical treatment knowledge and so on. There's still that recurrent pattern of people reacting in so often the same type of ways, with panic and anxiety and fear of where we might catch that disease or who might be transmitting it. And my perception is that different societies and different nations use history in different ways. So I think Canada on the whole has been taking this historical thinking into more of its policy work than other countries that seem to be a lot more ahistorical and don't take that longer lens look at the way in which our communities and cultures have responded to past pandemics. So yeah, I'm not sure exactly if that's answering the question, but that's where I see things.
Thank you for that. Another question that looks at the past and the present. Is there a precedent for how history treated the deniers, such as those that today are taking advantage of general confusion to advance the anti-vaccine movement? Let me repeat that. Is there a precedent for how history treated deniers, such as those that today are taking advantage of general confusion to advance the anti-vaccine movement?
Wow, that's a phenomenal question. I honestly haven't looked too much into that. I was looking into, with the particularly around the third pandemic photographs, instances of just healthcare providers and general scapegoating and blame that was going around at that time, but not so much the issue of maybe people providing misinformation or people taking advantage of new diseases to promote different ideas or alternative interpretations of treatments. There's definitely more of a history that I could have gone into as well, in terms of charlatans presenting different different ideas on how to treat diseases, but it wasn't something that I took very much time to look into, and definitely not in terms of how history has treated those types of deniers or hawkers of misinformation. And that's something definitely that would be of interest for me to pursue looking into further.
Sounds like a new research study, doesn't it?
It does, absolutely.
Now, you're a qualitative researcher, so I'm going to ask you a question that will help the rest of us who may not be actively doing qualitative research to understand how you approach this. When we were in the webinar with Dr. Jonathan Dushoff, as you know, is a professor in the Department of Biology at Mac, he was very clear about distinguishing what he was saying as fact from what he was saying as opinion. And being a quantitative researcher, that's easier for him than it is for qualitative researchers. So how do you, when you're looking at photographs from the past, distinguish between what represents fact and what represents your opinion or interpretation of what's going on in the picture? Can you help us with that?
Yes. So I think there's sometimes a little bit of a debatable point about also what is interpretation of certain facts as well. But with visual histories, there's a technique that I refer to often that has been described by a visual theorist by the name of Ariella Azoulay, and she talks about the practice of watching photographs. And this might seem sort of counterintuitive because photographs are static objects. But what she refers to by watching photographs is to try and reconstruct the arena of actions and actors that fall outside of the frame, and reconstruct all of the events that led up to that photographic situation, and also to try and trace the way in which the photographs have subsequently been used. And this is all in an effort to rebuild that history that is otherwise fragmented from just being left within the photographic record or documentary records. And this does require quite a lot of interdisciplinary approaches and looking at different material, not just the photographs, but also documentary records, different interviews, different correspondences, and so on, to try and fill those gaps to, as much as possible, avoid just adding your own opinion to it. But history is always going to be also an interpretive art as well. And so I think we have to always be attentive to the fact that we are trying to interpret it, though, as closely as possible to those experiences of the people that came before us, to be as respectful of their experiences as they lived them in the past.
Thank you so much for that. Another question. The individual says, thanks for sharing the amazing images past and present. Do you have any advice on best practices that photographers, amateur and professional, should apply when taking photos that include patients, healthcare providers, or just people in general? How can we take and share photos respectfully? So let me repeat that. It's a little bit long. Thanks for sharing the amazing images past and present. Do you have any advice on best practices that photographers, amateur and professional, should apply when taking photos that include patients, healthcare providers, or just people in general? How can we take and share photos respectfully?
Great, thank you. Yeah, this is a question that I get asked often, and I always think that my responses are a bit less than satisfactory, because there is no black and white answer. Despite there being black and white photography, there is no black and white answer to this question. I think as scholars and as photographers have continued to share pictures around the world and across time, there's been plenty of debate about this exact question, how to share photographs of people living through personal experiences in the most respectful way. At the present, I would say the most respectful way to do that is to do so with the consent of the people in the photographs. But that is not always necessarily possible either. Then I would say that it depends on how you're contextualizing the image and how you're using it, and how you might be writing captions for it or speaking about the photographs. But this doesn't solve all of the problems either, particularly if you're sharing photographs on the internet, where a photograph can easily be downloaded and repurposed for different uses. So there really is no simple answer to that question, but I think if you're approaching your use of photography in a respectful way, and you also put yourself in the position of the people that you're photographing and asking yourself if you would like your photograph in that situation to be shared with others, then that should be a guide for you to determining what is the best way to use the pictures. And sometimes the people that are in the photographs may have the complete opposite opinion of how we might think. So we may have been criticizing photographs as exploitative or discriminatory, whereas the people in the photographs, as some recent research is coming out with, shows that the people in the photographs were happy to have their pictures shared because they saw the distribution of those photographs as being more important than any embarrassment they might have felt in being photographed. So it's really complex.
That reminds me of that exercise where in the one of the Toronto newspapers, they asked people to decide whether they would have published a picture or not. It was actually in the newspaper. And you get so many perspectives on why or why not that picture should be there. It's absolutely gobsmacking, all the different perspectives, and sorting through that must be really a challenge for someone like you in your research.
It certainly is, and I think that's why I'm so happy to see that there is some research that's long overdue, but is finally happening, particularly in the area of humanitarian health representation, where there are interviews being done with within communities that are often represented in aid organization photographs to get their perspectives on the use and creation of these photographs, and then also working more collaboratively with communities on creating their own visual representations of their situations.
Okay, so back to our questions now, Sonya. This has been very helpful so far. Why do you think it took so long for many health units to start tracking racial data from COVID patients? Why do you think it took so long for many health units to start tracking racial data from COVID patients?
Wow, that's a very interesting question, and one that I'm going to be answering with pure speculation on my part. I would say that I think in an era where, from a scientific perspective, we know that race is not a real marker, that it's a social construct, that I think that medical epidemiologists and medical researchers were leery of trying to apply that kind of a category to something something that is not really of physiological relevance to COVID-19. But it does, we do know that racialization is part of the social determinants of health and can give us a bigger picture understanding of the impact of COVID-19 in particular communities, in particular specifically racialized communities. As to why it's taken a long time for that to finally become something that gets recorded, I'm not too sure why. Maybe they just hadn't been thinking about the way in which that social determinant of health can have such a big impact on people's experiences with this disease. But I suspect it otherwise has something to do with the fact that race is not considered a biological marker.
Okay. One last question. just to wrap up. As you know, Roland Barthes he generated some very thoughtful literary criticism, and he talked about when looking at a picture, there's often a punctum, something that jumps out at you from the picture. And I just wondered if you have viewed any pictures from COVID-19 where something jumped out at you and left an impression on you. Is there a picture that you could comment on?
Yeah, that's great. Yes, so yeah, punctum is really this this unexpected element within a photograph that captures your attention, and can sometimes be just even a section of a photograph that would otherwise not have been part of the photograph had the photographer been able to crop it out of the scene. To me, I think actually is one of the photographs from the slide of the images from Italy at the height of their overwhelm experience with COVID-19, and it was the picture of the people grocery shopping, because that was for me as well. It was only when lockdown really took part here in Canada, and I found myself all of a sudden, unexpectedly, becoming anxious, doing something that had been so mundane to me, that I realized that we were living in a very different situation than we had been weeks ago. And it was feeling that same emotion then when I was looking at that photograph after the fact, that my own perceptions on the global realities of this pandemic really started to set in. So it was, yeah, just the mundane type of a task of grocery shopping and that being photographed that really, I think, struck me the most recently.
Thank you so much, Sonya. Thanks, everyone, for those fascinating questions, and we hope this exchange has really helped expand your understanding of pandemics. A special thank you to Sonya, Dr. de Laat, for your excellent presentation, and the pictures were just really wonderful. The insights provided in the Q&A with our global audience, we really appreciate your distinctive contribution to this webinar series. Thanks again. Now let's quickly wrap up our webinar. Thank you for attending. We look forward to hosting the 9th webinar in our series entitled Searching for a Magic Bullet. This will be held on Wednesday, May 13th from 12 to 1 Eastern Daylight Time. And again, note this change is different from the early webinars where we started at 10:30, so it's 12 to 1 Eastern Daylight Time. It features Dr. Anja Krumijk, professor in the Department of Health, Ethics, and Society at Maastricht University, the Netherlands, one of McMaster's partners. In this webinar, you'll learn about the challenges of pursuing swift solutions for a complicated pandemic. If you haven't registered for webinar 9 or for the final webinar 10 in our series, please register through the link on the website globalhealth.mcmaster.ca/2020 webinar series. So enjoy the rest of your day, everyone. We look forward to your participation in our next exciting webinar. Thank you. Merci. Gracias. Dankjewel.